So I was asked to kind of focus on a few incidences that I can recall. One was very kind of stuck out more, I'll say, and so that's the one I have some slides on. And then I have a couple others that I was reminded of that we'll kind of go through. Sorry, the mouse wasn't working. So we're just going to kind of go through this lady's chart a little bit and kind of see where things could have been done differently so that maybe we had a little different management. Fortunately, I don't think there was any outcome issues in this situation. So this is a 78-year-old female who previously had multiple small surgeries, and then she had a very large spine surgery that is kind of a combination of what Jack was saying from the front and the back in his the previous talk. She had a 2-level corpectomy with instrumentation above and below, so it's a lot of surgery. And unfortunately, some of these patients with very bad bone, which is osteoporosis and some other things, they don't really take to the screws, and we can have complications long term. And as you can see here in this picture, this screw has a big halo around it. That's what we call that missing chunk of what should look like kind of dense bone. There's a halo around the screws, and that means they've loosened and they start pulling out. That's what happened to her. And so she was in my office a year after surgery, and she had loose screws, and you could see it on her back. You can feel the screws. It's painful because now she has bad motion, and so we did a surgery to fix this. Her H&P was performed actually not even, typically it's in our office, since you have to click on a scanned document to go back and look at an H&P. But this H&P was one of the ones where she had seen us, I guess, more than a month out from the office. So in that situation, we have to document a new H&P the day of surgery, which is even better. So she had a documented exam at 0650 hours on the day of surgery, 7/16, and it said low extremity strength, 4+ over 5 bilaterally. And I think one thing, and Carrie, you can correct me if I'm wrong on if it has institutionally already changed or is about to change, but we are fixing the documentation you guys have available to you, so they don't have the 10 different options that make things very confusing. We've done exactly what I think Jeff just showed, and it sounds like Jack did as well. The exact same score that we have, you guys will now have. It'll say, instead of the number, it'll say what the score would mean. If it's a 1, it means flicker of movement. If it's 2, it means movement with gravity removed, meaning they can kind of move it side to side, or if you remove gravity, they can move the arm or leg or whatever. And then there's, with 3, they can go against gravity, but any resistance, it's out. And then there's some resistance, and then there's the full motion. So you will now have that exact score, and this is the patient that kind of brought that to our attention. So hopefully that'll help make some things better.
And it's in the Epic production now, so it's not live yet.
Okay, not live quite yet.
So education when it is live. So.
Excellent. Thank you, Carrie. So, and then I thought this was very interesting when I went back. She had a pre-op evaluation actually from the pre-op nurse that went through and said, right dorsiflexion strong, plantar flexion strong, right lower extremity. They didn't actually comment on it, but so there was a preoperative assessment. At least had some right lower extremity musculoskeletal or muscular strength evaluation in it. So before surgery, then she went to surgery. She comes out and she has, and I can't tell when or who did this assessment, and it's not so much a who, but like I can't tell if it's on the 4th floor or in recovery. But at 1900 hours, I don't know which one that is. It could still be recovery because it was a big surgery to fix this. It says her right lower extremity responds to, and then if you could put the cursor over it, it says responds to command, and then under strength it says other comments. But if you go over there, it says something along the lines of weak. I mean, it's very vague. It's just weak. It doesn't say how weak. It just says weak. And that's why a lot of this needs correction, because now that's a documented exam that you guys are going to, let's just pretend this was the recovery room, because it's very possible. That's very difficult for you guys to now take that patient and know what that means. That's why it's so imperative to have this common language. oh, it's a 1, it's a 2, it's a 3, it's a 4, it's a 5. So now you know how weak. And then you can use your objective measurement to say equal or different. And then going through her chart continuously, we now see in the 16th, going through the 17th, right lower extremity motor response, it still says, strength. It has this little thing if you put your cursor over, it says weak again. And then the next assessment right here says flicker of muscle. So now we've changed our assessment. We went from weak as the documenting statement to flicker of muscle. Now, could you say that's a change in exam? I would argue that if the same person examining the patient has not changed their thing, yes, it's a change in exam. But we definitely know that's different than the preoperative documentation, right? So we definitely have a change here. And then to continue on into the morning, I think there was, and that overcomes gravity. So there was a fluctuation through the night. And then going until the morning, we now have can overcome, I think that also says gravity. You guys had two different ways to say something about gravity, and we're fixing that. So then we come in the morning at 7 a.m., and she's not able to move the leg against gravity. She's not able to move the leg against resistance. It's much more of a flicker response that was previously documented. So going back through, of course, you walk in and you see this, and the first thing you want to know is, well, when did this happen, right? Well, if you go back, it's really hard to tell when it happened. You can see where it says flicker in the chart there, but it also said week before. So was it the whole time? When did this happen? And there's very significant amount of variation in the documentation, and that should be a warning sign. That should be something where our team, you guys, should be, something's not right. I'm seeing changes from the preoperative to the assessment and the assessment by the preoperative nurse to the post-op PACU assessment and to my assessment, and then fluctuations in my own assessment. Kind of alarm bells should be going off. So there was no notification to the surgical team, and there's all this intra-observer variation. Even the same person had a differing exam from moment to moment. So what do I want you to take away from this? I think the most important thing I tell everybody I train: trust no one. Trust absolutely no one. Don't even trust me. If I come in and I say I see something, and you see something different, don't believe me. You say, no, I don't see this. Call me back in there. Make me look at it again. Make me prove to you that I am right or wrong. And that is how you don't miss things. Trust no one. That goes with documentation too, right? Sometimes, it's bad. It's not acceptable practice, but sometimes things get cut and paste. Different things happen. Different providers do different things. Don't trust even the documentation. If you see something that's not full strength, you need to confirm that is that patient's either baseline or expected or whatever it may be, especially in the setting where you see something documented where it wasn't like that before. So definitely trust no one, because you can only trust what you're seeing. That's all you can really do, and that's all you're going to be really held responsible for is what you're seeing. So use our documentation to your advantage, though. So if we have a note in there, and as you I'm sure know, almost to, and Jeff can probably corroborate this, to an annoying level, we have to sign a new H&P type thing every single morning on every single elective case we do. There's always an H&P to go back to. Sometimes you have to click a scan document, sometimes you won't. But there will always be a preoperative assessment by one of the providers on our teams. And that is, I would stress to you, you should know what that exam is on every single patient. That is something that I think it is your duty to, when you're getting the report from the recovery room or whatever it may be, that's your time to look at that, and then you can use that to say, hey, you're telling me this patient has weakness in the right leg. I'm looking at Dr. Beecher's note here. It says it was 4/5 strength. Are you telling me that it's different than that? Oh, okay, it's different than that. Have you told Dr. Beecher or his team? And then if the answer is yes, they are aware, you can feel a lot more comfortable. Maybe you still get the patient up and say, this doesn't seem right, I'm going to call, I want to verify. But trust no one and use our documentation. And I would even go further, challenge anyone who says to you, this patient has a neurologic deficit, especially an elective patient, right? An elective patient is coming to our office, not coming to the emergency room. So typically, not always, like Jeff was just talking about, there's patients with chronic myelopathies who do have some weakness and atrophy and a lot of instability issues and fine motor movement has degraded as well. But by and large, on a gross motor skills assessment, these patients are able to lift up their arms or move their legs, typically. So if somebody says, oh yeah, their right arm's not as strong as their left, challenge them. Get more details. Don't just say, okay, sounds good, move on to the next thing. Don't take it for granted that it's accurate. They might not like that you're doing that, but we don't care about that. And it'll make them better whether they like it or not. And it'll make your care for the patient better, which is what we do care about, right? That's what's most important. So even if they're like, they make me blah, blah, that is not a reason not to do it. That is even more a reason to do it, because that's not somebody who you're going to want to trust anyway. And again, did they notify anybody? If there's a neurologic deficit, somebody's got to know about it. That is just a must. There's never a time where there's a neurologic deficit and somebody doesn't know about it from the provider team. That has to happen every time. A couple tips. I think I just kind of went through this. Elective surgery patients will more often be neurologically intact, and so a deficit of any sort should be a red flag. You should notify somebody at that time, especially if you can't confirm that it's a pre-existing deficit. And one thing I haven't said yet, and maybe it's on here too, I don't think so. When I say don't trust anyone, don't trust the patient. The patients, I think Jeff actually just touched on it. There's going to be some patient who's like, oh yeah, my arm's a little weak, but it's okay. I'm sure it'll get better. I had surgery. What do you expect? No, that's not acceptable. If we documented 5 out of 5 strength and their arm's barely anti-gravity, you tell somebody. And then if we say, okay, yeah, blah, 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 I assessed them already in the recovery room. I noticed that. I'm trying some steroids or what it may be, fine. Or I think it's pain limiting, whatever, that's fine. But don't trust the patient. And then don't get tricked by the patient that complains a lot about a bunch of different things and then you miss the actual problem. So don't trust them either. Always kind of think critically. What was I saying about this? Oh, yeah. So, if something's kind of coming and going, that also should make a little unsettling thing to you, because something is dynamic. There's a process probably happening, and you should be aware, hey, somebody's got to know it was like this, and it was good, it got bad, it started to get good again, but you got to tell somebody about that. I mean, you should tell them at the moment it got bad. But variation is something that should highlight you to maybe notify somebody. And remembering that, especially in neurosurgery, these are often small corridors we're working through, and certainly there is the ability to have a dynamic process. A disc can reherniate, right? You can have a hematoma in an operative site. You can, and when you have these things, there's not a lot of room for the blood to go or to pool or to collect. So whether it's compressing the airway, which is probably a lot harder to compress than the cathecal sac or the sac the nerves sit in for a lumbar surgery, or if you're doing a posterior cervical, compressing the spinal cord itself, these things don't have a lot of room and there's not a lot of wiggle room. So when you have something like that, it can present itself rather abruptly, and those are things you got to kind of be aware of, and then an urgent intervention can correct it, right? So everything's very time sensitive in neuro. If you don't fix it when it's the problem, technically hour or hours, but every day that goes by, even outpatient settings, every day that goes by is another day that you're not as likely to fix the problem that you would have to correct. So the faster we identify a problem and the sooner we're able to intervene, the better the patient's outcome is going to be. So it's important that these are picked up. If you're in doubt, call, right? Don't ever, I know that I've been like, why am I getting this page? I know I've said that. Somebody's probably heard me say it. I've said different things about a neurodeficit. Never. If you're calling me about a neurodeficit, even if it's a pupil, and I kind of sit there and ask, hey, is the patient awake and talking to me or talking to you, and the pupils are asymmetric, I'll say, it's okay, that's fine, but I will never complain about a neurologic deficit call. No one should. If someone's ever complaining and you think you have a neurologic deficit, you can let us know about that, and we'll solve that internally. A neurologic deficit notification should never be something that you feel uncomfortable telling somebody about. It just shouldn't. I don't need to go into the other things where maybe notification is whatever, and you don't need to know our schedules of when it's appropriate. You just need to know if there's a deficit. Call 2 a.m. Call 1 a.m. Doesn't matter. These are the things that this is what you're here to pick up, really, and this is how you save somebody from having a permanent neurologic deficit. And if you don't feel confident in your examination skills, tell us. And when we're rounding, or if you want to just refresh or whatever it may be, when we're up there rounding, it takes literally 2 to 3 minutes to do a thorough, appropriate neurologic examination. So pop into the room when we're in there, which a lot of you already do anyway, and see. Often you'll see a focal neurologic exam at that time because we usually are doing a focused problem-based examination. But just say, hey, do you mind doing a full neurologic exam with us or with me, just so I can see what it is that you're doing when you're doing your exam? And the answer should always be yes. And if somebody's super busy and they got something, fine. But and if somebody says I really can't today, don't be discouraged from not doing it another time, or find me and I'll do it. But definitely, if you have any questions about things and about your own exam, ask us. We'd be more than happy. We're a small team. We all talk to each other. I'll even tell everybody, hey guys, the team might be asking you to go through an exam with them just to make sure we're all on the same page and that they feel comfortable with the exam, especially if we have any new hires that are kind of new to neuro. We should definitely do that. All right. So that's really my one patient presentation. Another one that was specific to me was I did an anterior approach called, as Jack was talking about, an OLIF, and we had a graph that was very challenging to place. And we had the x-rays in the patient because of the patient's size, and there's a lot of visualization difficulty. And somewhere along the line, and so this is not like isolated to nursing. I think this is going to be a great example of what's not isolated to nursing. Even on our team, we had variation in our examination over a weekend on that patient. And then I came in on Monday, and we saw this documentation, and I was concerned, and then we got a picture, and we saw that the hardware was off a little bit, and we had to take that patient back to surgery and replace the hardware to fix a foot drop. But that should have happened on the Saturday when it was noticed that there was a change. And so again, this is not a lecture to you guys. This is education for you guys, and it's not solely nursing and our team. It's our team as well, and our providers. And unfortunately, there's an old saying in neurosurgery that's taken from sports. It's contact sport, right? We're dealing with some real deal things when you're doing brain and spine surgery, and sometimes things happen to people, and we have to be very on top of we have to be on our A game all the time to make it so that the patient outcome does not suffer from a problem that can be detected like this. And fortunately, his foot drop did resolve after we corrected the placement of the graft. But things like that will happen, and it is exponentially better the faster it's evaluated, picked up, and addressed. And then similarly, there was a patient who had from one of my colleagues. He did a posterior cervical fusion, and a screw went into a neural foramen. And the patient, not the first day, but the second day, started to have arm weakness and pain. And it wasn't picked up overnight when it started to happen. It was picked up, it was documented, it was that, but it wasn't passed along until 7 a.m. on a Saturday when the on-call team now picked it up on their rounds, and then they had to go in and fix it. And the same thing, patient did fine. It was, a very correctable thing, but it's not always that way. So the faster and better our team, being you guys, are able to assess and find these things, the better we're all going to be and the better the patients are going to do. Any questions about anything I kind of went through or clarification? Okay. Anything specific outside of what I said in general?
So,
yeah.
Gotta be treated. I'm gonna ask a question.
Sure.
So you brought up a great point. I think Brenda might want to think about anybody new coming to the fourth floor, doing rounds with you guys, reading them, to actually do that full assessment, and maybe spend a couple hours with you guys seeing that repetitively, so that when they're out on their own after orientation, they are engaged around what you guys are looking for in that full assessment.
Yeah. So what I would stress for this particular type of education, the best thing is reps. So if we have people who are identified as new staff, new nurses that need that experience, I would try and we'd probably coordinate it, but at least at minimum we could identify when teams are rounding and have them go in with all the different teams and do that specific thing, and we can just notify that all 6 of us and our team that when we're asked to do that, you do it and you take them through thoroughly to make sure that they're getting that education. What I don't think is best for them, it's interesting and great educational experience, I have no problem with that, is following us for hours during a day, because that would not be high yield. Not saying we can't do that. I love having people come in seeing a brain surgery for the first time or spines, whatever it may be. Glad to have them come into the OR so they can see what they're taking care of afterwards. But I wouldn't be using that as the to stress that to get the education out. And if people, but going to the office, that's different. If somebody's allowed to come to the office, that's where you're going to see examination. So that's a better probable venue for that.
4 hours or whatever in the office.
Yeah, that's probably pretty smart. Yeah. Cool. Don't be shy. If there's a question, I'll answer. I guess Jeff and Jack were just so thorough that it's okay.